Thank you. It's a pleasure to be here with you today. I just want to briefly acknowledge my collaborators and colleagues who contributed to this abstract. Clearly, I don't do this work alone, so I want to make sure to acknowledge the team that's really worked on this. So Dr. Feely did a good job of telling you about MD Anderson, but I'll tell you a little bit more about us. So we were founded in 1941. We're celebrating our 75th anniversary next year, and very excitingly, we're going to have a boot run. So that would only happen in Texas. So we're very excited about that. You heard we are part of the University of Texas academic system. We have been a designated comprehensive cancer center. We were one of the first three with that designation in the U.S. in 1971, and we've been practicing multidisciplinary care for more than 2 decades. So a little bit more about us. We are a huge hospital. We have these data are about a year old, but we have over 20,000 employees, and all we do is cancer care. We have about, last I heard, 12 million square feet of space in the Texas Medical Center, which, if I did the math right, is a little over 1 million square meters. So we're huge, but we do have a huge patient population that comes to us, more than 125,000 a year. So we're very passionate, of course, about caring for patients and making sure that we're delivering patient-centered care. So additionally, a little bit about the Institute for Cancer Care Innovation. It was created in 2008, really to study the implementation of the principles of value-based healthcare and oncology, seeing how that would really work, taking it from theory to practice. So our areas of focus are patient-centered outcome, accurate costing, innovative payment models, and then enabling health IT. And so the work that we're doing encompasses a lot of these different areas, particularly focusing on outcomes. So a little bit of background on the problem that we faced, which I know is the same problem that you face here. Providers, payers, and patients lack access to timely, relevant outcomes. They need this information, particularly patients, to support informed decision-making and to make comparisons across providers and over time, but we know that we don't have this information. The data that are out there are mostly focused on the processes of care. They're very provider-centric, not patient-centric, and the outcomes that are available are typically collected in a research setting, and there's a long time lag before we actually see those. So we see a real gap there. And so our intervention sounds so simple. Let's just develop our own patient-centered outcomes, and then we'll integrate them into our electronic health record. So we are implementing a new electronic health record at MD Anderson in spring of 2016. So we're very excited about that, and that gave us an opportunity to really advance this effort. So our aims in this project were to apply an expedited patient-centered approach to creating disease-specific outcome measure sets for cancer care, and to establish routine data collection, including patient-reported outcomes in the electronic health record. So we know that this doesn't work if it's not made part of the clinical workflow, and it really needs to look at what outcomes are most important to patients. And in particular, something we knew was important early on was to make sure that we utilize not just clinician-focused outcomes, but really patient-reported outcomes. So capturing the patient's voice, their perspective on outcomes without any clinical interpretation. Because I don't know about you, but when I've read my medical records in a chart, I think, were we even in the same room? Because my experience from different visits and procedures, totally different than the providers. So that's why it's so important that we make sure that we capture the patient's perspective here. So using the tiered outcome hierarchy that was developed by Michael Porter, we use this with our clinicians. So just very quickly, Dr. Feely reviewed it in his introductory presentation, but essentially tier 1 is, did we accomplish what we intended to accomplish? So in this case, we're looking at survival and then maintenance or retention of functional status and quality of life. Tier 2 is really what patients go through in getting their care. So how quickly they get in, they start, they complete their treatment, as well as any complications that they experience. And tier 3 is how sustainable is their health. So we're looking at long-term cancer control and long-term maintenance of functional status and quality of life. So when we meet with our physicians and our other collaborators and experts, we outline a few guiding principles for them as we're going down this journey with them. First is that more measures don't equal better care. It's just more work. And so we really encourage them to focus on fewer, higher level measures that allow them to apply a more targeted focus to improving quality of care. We outline the criteria on the right whenever we're trying to prioritize the outcomes that have been identified. So we try to make sure that we're focusing on outcomes that are most important to patients, that are high impact for them, outcomes that are actionable by clinicians. We know there's a lot of things that we care about, but some of them we just can't address clinically at this point. Also, outcomes that reflect evidence-based care and validated care delivery models, and then finally outcomes that are feasible to collect. So ideally, I tell all of my clinicians I'd love us to select maybe 5 to 10 outcomes per measure set. We've never gotten there yet, but we really are trying to get down to just that bare minimum set of outcomes to collect. So we have a 3-step process that we use. The first takes about a month, and it's concept development. We have a team that comes to these meetings that have done research, pulled the peer-reviewed literature to highlight any outcomes, and particularly functional status issues that are commonly reported by patients. And then in these meetings, usually 2 to 3 meetings, we establish the measurement scope, so which diseases are we focusing on, which stages of disease, which tumor histologies. We also identify concepts. We ask them to give us everything that they'd like to collect, and then we start whittling that list down. And then if we can find preliminary benchmarks either internally or externally, we try to capture those as well. Then we move on to measure specification, which takes 1 to 2 months. This is where, of course, a lot of the work goes in. It's a little bit of a painful exercise getting into detailed numerator, denominator, inclusion, exclusion criteria. We talk about any existing data sources that we might have at the institution. Sometimes that's administrative claims data. A lot of times it's data that's sitting in a research database on someone's desk. And so we do try to identify where those exist and if there's an opportunity that we can leverage them. And then also talk a lot and really map out how this fits in the clinical workflow as well as the patient flow. And then finally, we have measure implementation, which we've done a few early implementations that took a month or 2, but really this takes about 6 to 12 months when we're talking about making this part of our electronic health record. So this is where we validate the concepts with our clinicians. Again, we're not doing rigorous testing here, but we are making sure that we have faithfulity with our clinicians and that we're really measuring what we intend to measure. This is where we do the build, design, testing, and implementation. Again, we've had the opportunity to implement 3 outcome sets through interim systems, which has been great, but our longer term approach is, of course, through our electronic health record. And then finally, this is where we're also designing the reporting mechanisms. So we do our best to incorporate patient perspective where possible. We're continuing to refine this. So Dr. Feely mentioned that we conducted a series of patient focus groups when we first started this. And so what we heard consistently from them, survival is important, but when they're going through that trajectory and starting their treatment, they're just trying to figure out how they're going to get through, how they're going to survive cancer care. So we know that while cancer care is our job, it's not our patients' jobs. And so really thinking about, well, what's most important to them, which is really how quickly can they get back to that sense of normalcy and get back to their life and really take care of their families, continue to work the things that we know that they have to do along with being a cancer patient. So the results of our studies, or of our work, so we have 6 outcome sets that were developed between 4 and 6 months. 4 of those will be implemented as pilots whenever we go live with our electronic health record in early 2016. And then by late 2016, we expect to have 21 outcome sets up and running in our electronic health record. So a Herculean effort. I have to give so much credit to all of our clinicians who've been dedicated to doing this and working with us along the way. And so I think my hope, of course, is that we'll be able to come back perhaps next year, the following year, and share with you the results of those outcomes and tell you about our success. So very quickly, sample set of outcomes. So again, we really tried to capture what we heard from patients. So tier 1, overall survival, ability to speak and swallow, important functional status outcomes for our patients, but also how quickly they get back to their sense of normalcy. Also looking at how quickly patients get in, start, complete their treatment, as well as any treatment complications that they experience. In particular, we are capturing unplanned admissions and unplanned emergency visits as potential opportunities to manage these patients better in the outpatient setting. And then we're also looking at long-term functional status, quality of life, and disease control. So I'll tell you about what's made us successful, except I can't go oh, there we go. So Patient-centered outcomes can be developed using an expedited timeline. Clearly, having the pressure of an electronic health record implementation behind us really helped us in this whirlwind effort to continue making progress. Not surprisingly, having provider and leadership buy-in is important. We always work with the willing, and anyone who comes to us and they want to work with us, we will always work with them, and that's been very successful for us. Also, strong project management. Again, we can't really linger on topic or linger in when we're facing challenges. We have to continue our progress in maintaining momentum. And then finally, short-term IT solutions are a great way to get early experience and early success in these efforts. So that's it. I want to acknowledge all of our collaborators. Thank you.